Hi everyone, welcome to this afternoon's Ask the Expert. As we know, PSC is a really complex disease and we still have some way to go to understand all the complexities of the disease. But there has been major progress in our understanding, and we do live in a time where there's more clinical trials for PSC than there has ever been before. So that's a really hopeful and exciting place to be. I'm really delighted today to be joined by Dr. Jess Dyson. Dr. Dyson is a consultant hepatologist at the Freeman Hospital in Newcastle. And Dr. Dyson is going to talk to us today about PSC, past, present and future. Thank you very much, Dr. Dyson, for giving up your time today. I'm presuming it's your lunch hour, so we're really, really grateful because we know how incredibly busy you all are. We have 83 people registered for this Ask the Expert webinar today, and I'm delighted that you're all able to join us. Please put your questions in the Q&A section of Zoom, and we will take as many as we possibly can. Please try and keep them quite short, and we will be able to take them all, hopefully. But as always, Dr. Dyson cannot give individual medical advice, but she will answer the questions in the best possible way. So without further ado, I'm going to introduce Dr. Jess Dyson.
Thank you very much. Good afternoon. Thank you, Paula and Mark as well, who's been organising in the background but can't join us today. Now, technology. Let's see if I can. There we are. So yes, I think actually, hopefully this talk is thinking about where we've kind of come from and also the more positive kind of landscape, I think, going forwards in terms of progress in PSC, which will affect people on the call in various ways. So I'm going to think about where we are in the past, where we are at the moment, and where we're hopefully going in the future. Just a few disclosures from work with some of the pharmaceutical companies. And if we think about PSC, so primary sclerosing cholangitis is a rare disease. So at the moment, we think it probably affects about 7 per 100,000 people. But you can see that there may be some suggestion of gradual increase. So this graph here up on the right, so the blue line is actually kind of all patients. And between kind of 1998 and going forwards, there's been a steady increase in the number of people diagnosed with PSC. The average age at which people are diagnosed is kind of late 30s. And unlike the other immune system liver problems, it's quite predominantly a male disease. So about 70% of patients are men. And there's a very strong link with inflammatory bowel disease. So ulcerative colitis or Crohn's or non-specific inflammatory bowel disease, with up to 80% of patients with PSC also having inflammatory bowel disease, which I think is one of the kind of current focus of research and trying to understand PSC, why it happens and how we might be able to improve treatments. This actually comes from one of the kind of excellent documents that the PSC support create, giving us a simple overview really of PSC, and it's a condition predominantly or classically affecting these larger bile ducts draining. So it's the drainage system of the liver, larger bile ducts outside, splitting up, and I describe to my patients almost like a branching tree to the larger bile ducts inside the liver. These ones can be seen on an MRI scan. And then the kind of leaves on the tree, if you like, are the tiny bile ducts out at the edges of the liver. And to have a close look at these ones and whether there's abnormalities, and then that's when you need a biopsy of the liver. And you can see that the gallbladder is attached onto your bile ducts and actually, again, is relevant in PSC, and it's one of the things we monitor, and we'll be having a think about that. And this is work, some of you will have heard me go on about this previously. So this is work from my PhD, where one of the commonest questions I get asked probably is, why does PSC happen? And in truth, at the moment, we don't know the full extent of that or understand it. But it does seem to be that it's variable kind of geographically, both internationally. There are kind of hot spots, if you like. And this is the northeast and North Cumbria. So where I work, Freeman is here, well, here in Newcastle. And this is a kind of hotspot heat map, if you like, showing pink and orange areas where there are greater numbers of PSC patients. And actually, if you then try and think about, is there a significantly higher rate of PSC in an area? Well, we can see there's a red spot over here. So this, for out of context, because you haven't got the whole map of the UK, this is over in Carlisle and Cumbria, so that's a very rural kind of land farming kind of area, as opposed to these green spots, which are a significantly lower risk of PSC, which interestingly is down in the kind of Teesside area, which is a very urban, sprawling kind of industrial area, which is interesting just in terms of often we see that disease is much more common in urban areas, so actually pollution, industry, etc., we tend to think of as being high risk factors for disease, but in PSC we're actually seeing the opposite, and I'll touch on that a little bit more as we go through. So yeah, why? So genetics, people are often, again, a common question I think is, well, am I going to pass this on to my children? Is it something I can give to somebody else? And there are genetics in PSC, so there probably is some increased risk associated with what genetics you have, but it isn't an inherited disease. You don't directly pass it between generations. And as such, we don't, there is no kind of formal family screening for PSC. And actually, because it's such a rare disease, even if you have a slightly increased risk because of your genetics, it's very unusual to get 2 family members with PSC. We've mentioned the idea of the environment. So whether there's a genetic kind of makeup, if you like, with something in the environment that then tips you into having disease is one of the things. There's lots of research. We talked about the fact that inflammatory bowel disease is extremely common. So actually, what is it between the bowel and the liver? So your bile acids go round and round and round and round between your bowel and your liver and your gallbladder. And actually, is there something, there's trillions of bacteria in your gut and your bowel, whether there's something about those bacteria that either is a risk or protection against liver disease. And PSC is felt to probably be an immune system problem. So whether there are changes in your immune system, you know, could you have had a virus or something that changes or triggers changes in the immune system that then leads on to disease? So in truth, these are all more kind of questions at the moment. We have more questions than answers, but are ongoing areas of research. And this is quite an interest. So this is America, this is New York. So areas most of us will have heard of, and some of you will have had the fortune to go to. So Staten Island, Brooklyn, Queens. And this is looking at patients with PSC on the liver transplant waiting list in America. And actually these triangles here are looking at what they would call super toxic fund waste sites, so what we would call a landfill site essentially in the UK. And actually they found that there were higher rates of PSC patients needing transplants around areas where there were landfill sites. And again, that's bringing us to this idea of, is there pollution? Is there some form of kind of toxin associated with disease? So I think that's quite interesting. And this going back to my PhD work, so we've mentioned that actually urban areas, so industrialized, polluted areas, you often see a higher risk of disease. So cancer, classically, higher rates in industrialized, polluted areas. But actually in PSC, we're seeing the exact opposite. So these numbers, don't worry about the kind of the numbers themselves, but actually all the numbers here are negative. So if they're negative, it means it's significant. And actually the relationship is negative. So there is more disease where it's less urban. So actually there's more PSC in rural kind of leafy farmland type areas, which is very unusual for disease. And the other one, we looked at all sorts of different factors. So thinking about other things like coal mines, and we looked at motor vehicles, so thinking about that as being a marker of kind of traffic pollution. They didn't show any form of signal, but actually right down here at the bottom, so the Townsend score, just doing a talk, yeah. Let me come in, just yeah. No, come in. Sorry, my office buddy's just appeared. Don't run away. Townsend score, so that's a measure of social deprivation. So we think about, quite often we see that disease is more common in areas that have higher social rates of social deprivation. But actually, again, in PSC, you're seeing across the board, there's a negative numbers here. So actually in PSC, disease is more common and more affluent, kind of better off, if you like, higher income areas. And again, that is the exact opposite of what we see in most diseases. For example, stroke, heart disease, cancer, we usually see higher rates of those in more deprived areas. So PSC seems to have a completely different signal to most other disease in terms of risk factors. And the other thing I think I very commonly get asked is, what is there something I can do? Is there something I've done wrong? Is there something I can do to help myself? Is there something in life that we've come across, been in contact with? This was a big study from about 20 years ago now, actually, thinking about kind of life risk factors, if you like. And actually, there was a relationship between if you'd had your appendix out. Now, obviously, that's not something within your control, but HRT use, so this thinking about hormone replacement therapy, and also recurrent UTIs. So this builds into this idea: could you have had an infection, for example, that then triggers disease? And actually smoking, smoking has a relationship with both PSC and inflammatory bowel disease. That doesn't mean you should smoke, though. That's not but it is just interesting in terms of the toxin and infection story about these risk factors for life exposures. And what should I eat? Again, a question I very commonly get asked. I mean, the kind of stock answer to that, I think, that most doctors give is, healthy life, healthy lifestyle, diet, exercise, activity, all of which I think is good advice. Interestingly, there is a signal for kind of oily fish, high, regular fish intake in the diet potentially being protective. So for things that are on, I can't point at the screen, things that are on the left-hand side of this line, potentially associated with lower risk of disease. So actually kind of whether fish is good for you, and fish has lots of omega-3 in it. And if we think about how we diagnose PSC, it can still sometimes be challenging, and some people in the audience may have come across this, that people struggle to give them a firm diagnosis, certainly initially. And it's really a combination of potentially how patients present, so symptoms being one of them. So for example, when we'll talk about symptoms in more detail, but itch, for example, being one of the symptoms people with PSC describe. Blood tests, so liver blood tests, most commonly the alkaline phosphatase, or ALP, which is a marker usually associated with the bile ducts. You can get immune system proteins called autoantibodies. They're not very helpful in PSC, unlike the other liver system problems. And really the mainstay nowadays is MRCP. So that's a specialist form of MRI scan. So it's the long tube scanner that some people do find quite claustrophobic. But that gives us a really detailed view of the larger bile ducts inside and outside the liver. That's kind of pretty much replaced ERCP. So we did used to use ERCP. So ERCP is a more invasive test. It's a camera test and comes with risk. So we don't really use ERCP for diagnosis at all now. We use it if we want to either kind of take some samples or even kind of stent open one of the bile ducts, for example. And liver biopsy can be really helpful still, and I do biopsy quite a lot of my patients after talking it through with them. So that gives us actual bits of liver tissue, so it allows us to look at all the cells in the liver, and it also allows us to look at those tiny bile ducts in the edge of the liver as well. So putting that whole picture together can give us a diagnosis potentially. And this little picture here, so I'm not sure I'll be able to convince you of this, but this is from a biopsy. So if this is looking at the bile duct kind of end on, if you like, so looking kind of down the tube. And if you read a textbook, it tells you that it's meant to look like onion skin fibrosis. So kind of rings like this of the white fibrosis and the scarring, and that's the kind of classic biopsy sign of PSC. So let's think about symptoms. So primary biliary cholangitis, which, if you like, is the kind of sistership of PSC and quite is still rare but more common. I think PBC is very well recognised to have lots of symptoms. And actually, I think until relatively recently, probably, we underestimate and still do underestimate the number of people who have symptoms in PSC. And if you look at some studies, 50% or even more potentially have symptoms. when they are diagnosed, and then about another fifth develop symptoms as time goes by. That can be fairly non-specific things, you know, fatigue, lethargy, you can get abdominal discomfort. And then if you have any of the complications with infection in the bile ducts, which again we'll talk about shortly, you can get temperatures or fever, and people often, well not often, but can get itch. One of the things we're working on kind of as a community is trying to get better at assessing symptoms for patients, and what we call PROMs, so patient reported outcome measures. It would be, I think, really beneficial to try and develop one that is specifically designed for PSC in its own right. And I think, as I've said, PBC, it's well established about symptoms and focusing on symptoms as part of disease management. And I think we really can learn a lot from that in the PSC world. So cholangitis, so that's the kind of medical term for if you get infection within the bile ducts. And this can be kind of fairly mild, you know, subtle symptoms, but actually can make people poorly very quickly. So we would always try and counsel patients that if they have pain in their abdomen, particularly kind of in the right upper side of their tummy, if they develop itch, certainly if you were yellow, so if you develop yellow skin or eyes, if you have some temperatures, if you start, you notice your urine starts going dark, or your motions when you go to the toilet become pale, or if when you're having your blood test monitored, there's a sudden change in your liver blood tests. Those are all things that make us think about infection. And PSC support actually have a beautiful kind of credit card sized information thing, so you can carry it around in your handbag. And actually, if you go to seek medical advice, it's often quite helpful to show that to somebody who you're seeking help from, because PSC is such a rare disease that actually even, you know, you can be the best doctor in the world, but you don't know everything about every disease. So I think that can be really helpful for people. And I mentioned this idea of the fact we underestimate symptoms. I think this again is work done led by PSC support. And on the left here is kind of worldwide data, and on the right is UK data. And actually, interestingly, we found a much higher rate of symptoms than has ever really been reported in kind of true research studies per se. So 90% of patients are describing a symptom of some type, and actually nearly 40% of people are describing itch, and which I think is much higher than most people would have assumed. This is really important, and I think that fatigue is one of the things that we really struggle to treat, but actually can have a massive impact on people's quality of life. So until we really kind of acknowledge these symptoms are important and people experience them, I think it's very difficult to address them. So I think that's one of the key messages really for doctors, is to ask about symptoms and treat them appropriately where we can. And if we think about itch, so again, PBC, it's very well recognised, and we do actually have lots of treatments. If you ask a patient with liver disease if they have itch, they're very clear, yes, I do. And actually, if you say, could you describe it for me? The very kind of classical textbook description, which almost all patients will give, is that it's worse at night, it's worse when I'm hot, it's worse if I'm in a hot shower, and it's classically palms of hands and soles of feet. Clearly, you need to make sure there's nothing else going on. Is there something blocking the drainage of the bile ducts? And important to remember, particularly in young females, iron deficiency. So interestingly, being low on iron makes your itch worse, and that's something we can very easily treat. And there are, in terms of treatments, as I say, we actually do have treatments. So I think it's incredibly important we actively ask about itch and then aggressively treat it. So we have a number of medications. And even in it's rare, but in rare circumstances, we do undertake liver transplantation, which obviously is a cure for PSC, in order to treat itch if we can't treat it with anything else we currently have available. And this is just my kind of personal ladder of how I think about itch in terms of the medications we have. And the details in some ways aren't so important, but just to say we do have a number of treatments. We start here at the top. So some of you will have taken cholestyramine, cholecephalam, or Questran. So those are, they shift your bile acids. So they give you a higher, so they can be a bit manky. I'm not sure that's a medical term. They don't taste very nice, the sachets anyway. And after that, we're thinking about lots of different, they're targeting lots of different things because we're not entirely sure why people get itchy. But rifampicin was actually an antibiotic, and well, is an antibiotic for tuberculosis originally, but is actually a very good drug for itch in some people. Gabapentin, some of you might be on it for pain. Actually, it's good for itch. Naltrexone, sometimes tricky to tolerate, and then sertraline, again, some people will have heard of this in the setting of, as an antidepressant, but can be very effective for itch. And then I suppose the newer kid on the block, so bezafibrate. So fibrates are licensed for cholesterol or management and have been for years and years and years. But there's recently been a huge amount of interest in bezafibrate, both for improving blood tests and also for improving itch. So we're increasingly using that. Certainly in PBC, we use it a huge amount, and in PSC, we're beginning to use it as well. And if we think about, we've mentioned that itch is, in this study, reported by 40% of people in the UK who have PSC. But actually, if you then narrow, burrow down into who's getting treatments, actually, we're really not doing very well in terms of how many people we give treatment to. So if you look at the UK, if you think about all the people with itch, actually only less than 2/3 of people are actually getting any treatment for that itch. So in my view, that's not good enough, and doctors need to be doing better with that. And fatigue, we mentioned this earlier on. So fatigue is really challenging. People are exhausted, activities of daily life, getting out and about, socialising, work, children, all of those can be impacted. And we need to remember to think about other things. So could there be another cause? So could you have an underactive thyroid? Could you be deficient in some of your vitamins? It can be quite difficult to tell apart if people have a kind of low mood or depression and how that interacts with your disease. And of course, there are some medications that make people feel very tired. So always thinking about, whether there's something we can change. And the temptation, of course, when we're, extremely fatigued is to do less. But actually, there's quite convincing data that if we can encourage activity, then actually that's very positive, that it drives energy levels up rather than kind of sapping energy. And this TRACE algorithm here, or TRACE abbreviation that I've got on the right here, was developed by my colleague, Professor Jones in Newcastle, originally for PBC, but actually I think the same is true in all diseases that have fatigue, thinking about underlying causes and helping people kind of cope with the effects, adapting their lifestyle, potentially adapting their working patterns if required. And we'd mentioned at the beginning that I think all of a sudden we're seeing an explosion in trials in PSC, which can only be a good thing. For years, as you know, at the moment, we don't have a licensed therapy for PSC, but hopefully in the relatively near future, we will see that changing. If we think about itch being the symptom we can target, then all of a sudden we've got trials with potentially some positive findings. So these are the kind of big kids on the block at the moment, what we call the IBAT or the ASBT inhibitors. So they're trying to block that relationship between bile acids and helping the bile acids then effectively poo out your bile acids rather than them making you itchy. And there are various trials ongoing, certainly the one at the bottom here, the Velixabat, the Vantage trial, which is being run by Mirum, who are a drug company. So we're certainly recruiting to that in Newcastle at the moment. And early phase data actually is quite exciting, I think, for some of these drugs. And I think the other thing that we talk about quite a lot in clinic and I think on kind of the forums and things is the role of ursodeoxycholic acid. So urso is a bile acid, and I'm a fairly simple doctor. I think of it as being a kind of good bile acid. So we give urso and you give people more of the good bile acids to kind of dilute the bad bile acids. And it helps it flow out of the liver, and it also has a direct protection effect on cells within the liver. Now, the kind of sticking point with all of this is actually there isn't a good high quality trial that shows urso to be good for people. This is the largest study looking at urso compared to a dummy drug, so the placebo, in over 200 patients. And actually, they didn't show a significant benefit with Urso. Although the blood test did improve, there were no difference in symptoms or quality of life. However, I would just flag up that this trial wasn't big enough to demonstrate the difference they were looking for. And you can see here that those two lines do separate out. So I think although it wasn't a positive trial in the sense it didn't show Urso was better than the dummy drug, we didn't write Urso off at that point. There is the other issue with Urso was there was then concerns about high dose Urso. So you should not be using very high doses of ursodeoxycholic acid in patients with PSC. And actually there were high rates of complications. So when they did a trial of this, it was actually stopped early because there were complication rates in terms of liver failure and even needing transplantation. But the kind of really quite recently, actually, there was big data. So some of you will, or many of you probably will participate in UK PSC, so the National United Kingdom study for all patients with PSC. And there are worldwide kind of big studies like this as well. And actually, if you look at big numbers of patients, you can see very clearly that ursodeoxycholic acid improves the ability to normalize liver blood tests in patients with PSC, and that potentially maps on to better long-term outcome. So certainly at the moment, personally, I offer ursodeoxycholic acid to all my patients with PSC. My reasoning for that is at the moment we don't have an alternative, and also it's a very safe drug, so it has very few risks associated with it, and the majority of people will tolerate it without problem. And that has been reflected in the guidelines. So both America and European guidelines have changed. And so now I advocate for considering ursodeoxycholic acid. And the UK guidelines were just in the process of rewriting, and I suspect we will follow suit as well with that. So it's certainly a discussion to be had in clinic about whether you want to take Urso. If we just change tack slightly and have a little think about inflammatory bowel disease, so we've said at least 70, maybe more % of patients with PSC have inflammatory bowel disease. And it's important to say that patients can be asymptomatic, so have no bowel symptoms, no diarrhea. So actually, when somebody is diagnosed with PSC, we would advise that a colonoscopy, so a camera test to look right round the large bowel, should be offered to all patients. If that colonoscopy is normal, provided somebody doesn't develop any symptoms, then we would suggest a repeat colonoscopy every 5 years to keep looking for inflammatory bowel disease in case it develops. However, if you have inflammatory bowel disease, then actually we would suggest a colonoscopy every year. What we want to do is make sure we're having very good control of colitis, good control of inflammation, and actually that is very clearly demonstrated to pick up abnormal cells, cancer earlier in the disease process. And actually, if you look at if you flip it on its head, if you like, and go looking for PSC in patients with inflammatory bowel disease, then about even up to 9% of patients may have PSC. So that isn't routine at the moment, but in some it is in some countries, but not in the UK. And the microbiome. So this is a kind of very sexy topic at the moment across all sorts of different bits of medicine and research. So the microbiome, we talked about the bacteria in the gut, and how the gut and liver talk to each other is a massive focus of research. And could it be that actually the bacteria in the gut, if they're changing, is that triggering immune system imbalance? And it's a very complicated area to study. It's got so many things that affect it. So diet, bile acids, infections, medications, antibiotics, and even actually, interestingly, there's some suggestion that mood itself, so low mood or high mood, affects the bacteria in your gut. So it's very, very interesting. And this is, again, the details don't matter in some ways, but just to demonstrate that actually, if you look at, so here along the top, this is PSC patients versus healthy people, looking at literally the bacteria in their stool, in their motions. And you can see that there are some bacteria which are higher numbers in patients with PSC as compared to kind of healthy people. And this one here is, look at these ones on the bottom again, are looking at PSC patients versus those with just inflammatory bowel disease. And again, there are differences in the numbers of different bacteria, both kind of good bacteria and bad bacteria, thinking about whether this is in some way driving the liver disease or in fact could be protective against liver disease. And I think the future is actually very positive in terms of the ongoing trials and things, but I think it would be remiss of me to not mention some of the more difficult aspects of PSC to talk about. People with, particularly with inflammatory bowel disease, do have a higher risk of cancer in the bowel. But we know that going looking for it, checking for it, and that's why we do an annual colonoscopy, is associated with lower cancer rates. And we would suggest a good quality endoscopy annually with biopsies of the bowel to look for abnormal cells, even if they can't be seen with the naked eye. And it's tricky, and different places do different things, because of course children who are then turning into adults, when do you start surveillance? But there is suggestion that you should be thinking about annual surveillance even in teenagers. And again, it gives us something that we know that we can control. So if your colitis is well controlled, that maps very well onto a lower cancer risk. So something that we really try and kind of fairly aggressively treat colitis in patients with PSC. And hepatobiliary cancers, so these are cancers of the bile ducts, the gallbladder. Patients with PSC are at increased risk of those types of cancer if you compare them to the general population. And we just need to be, cautious of this and aware of this. So a sudden change either in you and how you feel, or in the blood tests, where, itch we've mentioned, and very much, jaundice is something we do take very seriously, so the yellowing of the eyes. Or if you're generally unwell, and weight loss is something that we always kind of think about as being a feature that needs urgent investigation. Bile duct cancer, kind of known as cholangiocarcinoma, does affect patients with PSC. It is extremely rare in children and young adults, and much rarer in just the small duct disease. So if you've just got PSC that affects the tiny bile ducts at the outside of the liver, the rate of bile duct cancer is much lower. We also keep a really close eye on the gallbladder. So gallbladder polyps are very common kind of in the general population. They affect about 10% of patients with PSC, but we know that patients with PSC do have a higher chance of developing cancer within those polyps. So actually, again, we would keep a close eye, and we would take somebody's gallbladder out if those polyps are growing, in order to kind of, if you take the gallbladder out, then you can't, the polyp can't develop into a cancer. So we would certainly have a low threshold for taking somebody's gallbladder out if they have PSC. And I think one of the really tricky things is, how do we check? How do we go looking for cancer? If you're under my care, you probably get more scans than there's. Well, whether it's right or wrong, I do a lot of scans. They're so interesting. This is fairly recent data from just a couple of years ago now, suggesting that actually some form of imaging on a yearly basis, and kind of planned, not waiting for us to have a problem, but routine imaging to look for problems, is associated with improved survival. Now, whether that be an ultrasound or an MRI scan, or whether you should alternate, there isn't really kind of firm data about that, but essentially being aware of the risk of complications and screening for them is a good thing. And a word about liver transplantation. So obviously liver transplantation is a cure for liver disease, and the same is true in PSC as with other diseases. And the reasons to consider transplant are the same, broadly speaking. So if somebody's liver is beginning to fail, so if you're starting to see that the liver's not making blood clotting factors, it's not making proteins, or if you're becoming jaundiced and yellow, then those are certainly things that would start to have that conversation about whether we would need to consider transplant. The things that are different in PSC to any other form of liver disease is the cholangitis, so the infection in the bile ducts. If somebody is getting lots of infections in the bile ducts, which are making them poorly, that they're having to go into hospital for, getting intravenous antibiotics for, and that we can't control, then that in itself is a reason to be talking about transplantation. And I mentioned itch. So actually, most people we can control our itch, but there are a very small number for whom we have to think about transplant. And sadly, again, with some of the liver diseases, even after a transplant, you can get the disease back in a small number of people. And that there's various work going on about thinking about how we can reduce the risk of PSC coming back in a transplant. And one of the things that we know is important is to try and really keep on top of colitis. So if the inflammatory bowel disease is well controlled, or if we find new inflammatory bowel disease, we need to get on top of it, as that can be a risk factor for PSC coming back. As it stands in the United Kingdom, if you were to develop a bile duct cancer, then that would mean actually transplant was not an option for somebody. But actually there's now, just kind of hot off the press, if you like, there is now a service evaluation. So nationally, we have developed a protocol to think about actually doing liver transplant in very specific circumstances, very specific criteria as a treatment for cholangio, so cholangiocarcinoma, so for bile duct cancer, as a complication of PSC. So I think that again is an exciting step forwards in terms of increasing our potential treatment options for patients. And going back to this idea of the future being much more positive, I think, in terms of where we're going. So there are now, for the first time, lots of trials in PSC. We're thinking about reducing disease risk, so the risk of needing a transplant or the risk of developing cancer. And we're also thinking about improving symptoms, so predominantly really itch at the moment. We've mentioned these already. This is one of the kind of big ones at the moment. So nor-ursodeoxycholic acid, so that trial is completing, so hopefully we'll get to see the outcome. So essentially I think of it as kind of a souped up form of urso, again helping the bile flow in and out, probably reducing inflammation. And again, it's a high quality trial, so it's placebo controlled, so that we're comparing nor-urso to a dummy drug, but neither us nor the patient knows what drug they're taking. And the early data suggested that actually there was a significant improvement in blood test levels, and actually it being a very safe drug. So hopefully we'll hear the outcome of that very soon. And then UK PSC, just to push for people to take, if you want to be involved, if you want to get involved in research, and UK PSC is a fantastic setup. Everyone in the country is eligible to take part. And there's kind of lots of studies going on, but just to pick out a few. So reducing bacteria in the gut, so vancomycin is an antibiotic, so that's one of the things that's interesting. Can we change the bacteria? So actually you can do a whole kind of fecal transplant, and that's the Fargo study being run out of Birmingham. And then can we affect how your gut absorbs toxins, so actually using kind of little carbon beads to affect actually how the gut actually absorbs things. So lots of really interesting stuff going on. And this is just a bit of a plug. So this isn't my study. We are taking part in it in Newcastle, but this is open relatively recently, run by Shahid Khan and Simon Rushbrook. So this is a national study, and it is a massive undertaking. They are aiming for nearly 1,000 patients. And I think us as a community, if we can pull this off, would be a huge thing. So this is interesting, just looking at aspirin, a drug that we're all aware of, and really thinking about actually this is focusing on reducing cancer and overall outcomes in PSC. So I think it's a very exciting thing that they've managed to get huge amounts of funding for, and I'm very supportive of it. So hopefully it will be fairly attractive to patients, because aspirin is something we're all aware of. So if that, and there are more and more sites coming on board around the country. Let's think, if you're thinking about the long term, actually most patients with PSC progress slowly. Things don't tend to happen quickly, which is obviously good. And actually, as time goes by, outcomes and prognosis in PSC get better and better. We do more transplants for PSC now than we used to, but actually that's saving people's lives. And the prognosis or long-term outlook for PSC is better than it ever has been. We're increasingly picking disease up early. That's partly because doctors and the public are more aware of disease. We have better and better technology, with the MRI scanners being better. And also people are having liver blood tests done for all sorts of reasons. So well man or well woman clinics, diabetes clinics, all sorts of things. And we know that actually if you're young at the time of diagnosis, female, or have just that tiny small duct disease, or actually near normal or normal liver blood test, those are things that put you in a lower risk group. So yeah, just to wrap up, I think the future, actually there are lots of positive steps, and I would just again point you towards PSC support. Their website has a fantastic trials, I'm not sure what the right, it's not advertising, but information provision about trials that are ongoing across the country, which centres are running them, so that for people who do want to get involved, it gives you a really good information base. And all of a sudden, having never had trials really in PSC, we suddenly now do. It's a huge collaborative effort. The Norezo trial that I mentioned is 8 centres internationally. And actually the Aspen PSC trial, as I say, if we can get 1,000 patients into a PSC trial, that is going to be a huge, huge achievement. So yeah, I would advocate getting involved if you want to. You're under no pressure to take part in trials, but I think it's a very positive. And actually, if we all kind of club together, so the doctors, patients, the drug companies, the funders, the research funders, and raising awareness of PSC, I think all of a sudden, hopefully, we're really moving in a positive direction in terms of better treatments being available. So that was all I was going to say, Paula. Thank you.
Thank you very much, Dr. Dyson, for that comprehensive explanation there. We've had a few questions in the Q&A section, but I am encouraging you all to have a think now about your questions and put them in there as soon as possible. We've got about 15 minutes to go, and Dr. Dyson will do her best to answer those questions. I don't think I introduced myself, and I know it says it on my slide, but for those of you who don't know me, my name is Paula Hanford. I'm the CEO of PSC Support. So I'm going to start with the questions in the Q&A section. You mentioned, Dr. Dyson, PBC in your presentation. Can you tell us the difference between PSC and PBC, please?
And actually, it might be easier if I just, oh Lord, oh heavens, if I just go back to this diagram, actually, Paula, because I like, anybody who comes to my clinic will be sick of me drawing slightly poor quality diagrams of things, but is that going to work? Yes. So here, so we talked about this kind of branching tree idea. So PSC, predominantly these bigger ones, but it's these tiny little ones out of the side. So PBC just affects the small bile ducts. So you don't get any large bile duct change, so you can't see changes in the bile ducts on an MRI scan in PBC. But you can in PSC. So essentially they're both bile duct diseases, but PSC is generally speaking the larger bile ducts, and PBC is generally speaking the smaller bile ducts. So if you were going to do a biopsy, that's what you'd be looking at, the smaller bile ducts.
Great. Okay, thank you very much for that. You mentioned, we had that nice diagram, didn't we, about foods and the effect of foods on PSC. And the question is, does eating the right food, fish, for example, help when you already have PSC, or only to prevent it occurring?
Yes, that's a good question. I don't think, in truth, I don't think we know the answer to that. I mean, I suppose you're thinking about a trigger versus risk for getting worse, aren't you, really? I don't think we do know the answer to that. The studies that have been done are about people's lifestyle intake, etc., over periods of years. There will never be a trial that will answer that, I don't think, because also we don't know when somebody actually develops disease. So, you know, if I was diagnosed with PSC tomorrow, I don't actually know whether I've had it for 5 years, 10 years, 20 years, age. So yeah, I think the concept still at the moment, probably all we can do is think about the kind of idea of healthy lifestyle, all the kind of general rules of health. Whether we know that in due course it reduces inflammation in the liver. For example, coffee, for example, is good for the liver. Actually, coffee does protect the liver over time going forwards. So it may be the same, that actually there is a protective role of some foodstuffs or some oxidants or vitamins or what have you. But at the moment, we don't have confirmed data to support that.
I met somebody who was absolutely delighted. She was at our last information day when she heard that coffee was a protector of the liver. She said to me, "Is that true?" And I said, "Yeah." She was like, "Oh, brilliant," because she obviously drinks a lot of coffee. We haven't got many questions. I've got a couple of questions, but I am encouraging people to put your questions in the Q&A section of Zoom, and we will take those. And we've just had a couple more actually, so that's good. What's the average lifespan after a transplant? Somebody's asking.
Yeah, so nowadays, 10 years survival, well, 20, lots of people live to 20 plus years post-transplantation. There are lots of factors at play in that, but we have whole cohorts of people who are coming to transplant clinic, well, not transplant, but normal clinic, I suppose, 20 years after. The national survival rates for liver transplantation are very good in the UK. It's not, and actually PSC survival is
particularly good, yeah.
Diseases in terms of outcomes post-transplant. So actually probably the best overall is PBC in terms of outcomes from liver transplantation, but PSC outcomes are very good as well. So yeah, there are lots of variables, of course, aren't there? And actually people who have a transplant, it tends not to be liver disease, which is the problem in the future in terms of what is a life limiting, because of course, just because we've got, you know, I might have autoimmune hepatitis, but I'm still at risk of heart disease and stroke. So actually in terms of protecting people's transplants, actually we really tend to focus on all those other things. So, you know, cholesterol, blood pressure, not smoking, etc., to protect people's, because transplants, and actually it's not quite often not liver disease that affects the transplant in the longer term or limits people's lives in the longer term.
Thanks for that. So question here about coffee, going back to coffee. With coffee, does it matter whether it's caffeinated or decaffeinated, instant or beans? Obviously, I think those affected by PSC are really keen to do something for themselves. So this seems to be a question along those lines. So can you answer the question about coffee, please?
Now that is, I think it's general. I don't know, I have to confess, I presume it's an antioxidant effect, but I don't think it's the caffeine itself that's of benefit. I think that's true, but you might don't quote me on that. I think it can.
I've heard somewhere Dr. Dyson that it's the coffee rather than the caffeine or not the caffeine.
Yeah, so I think it's the coffee itself. So I don't think it's about caffeine or preparation, as in, you know, coffee bag versus bean or whatever. I think it's the coffee itself that's the thing that's good.
Yeah.
But yes, apologies if that's not true, but I think that's true.
I do as well. Somebody's posted that they are 27 years post-transplant on the call for PSC, so that's amazing. 27 years, amazing. And thank you for sharing that with us, because I think that will be very comforting to a lot of people. Somebody said, still a little confused around PSC, PBC. Can you have both? Is PSC always searched for if you're known to have PSC, and which is worse? Interesting.
Okay, I'll work through those if I miss any of that out. I mean, theoretically, you could have both. It is vanishingly rare. So I look after, because I run the service in this part of the country, I've got 3,000 patients, and I have one patient with true PBC and PSC, so it is vanishingly rare. So it's almost kind of, no, it doesn't exist, but never say never. In terms of do we always search? So yes, I suppose, but if somebody was to come to us with an abnormal liver blood test, for example, we would go through a whole kind of standard approach to look for all causes of liver disease, immune system problems being what we're talking about today, but would include PBC, PSC. We'd also think about, viral hepatitis, fatty liver disease, alcohol-related liver disease, some of the weird and wonderful things, iron overload, called hemochromatosis. So yes, it's about, you start with your kind of I suppose classically start with your abnormal liver blood tests, and then do tests to kind of narrow down into a diagnosis. So yes, certainly PBC and PSC would both be on that list of diseases you started off with, and then trying to whittle down by, not wanting to confuse them. So PBC is different in the sense that it has some very specific blood test findings. So actually PBC is much easier, generally speaking, is much easier to diagnose. Because we have very specific blood tests that we can do to look at the immune system for PBC, which don't exist for PSC at the moment, anyway. There's another part of that question.
I think it was, which is worse?
I suppose it depends how you kind of define worse. If you have, low risk PBC and no symptoms, then obviously that's a kind of but I can't quite think how to phrase that. PSC and PBC both have problems in terms of some patients do develop advanced liver problems, and we do transplant for both diseases.
Yeah.
PBC, even though I think we underestimate the symptom burden, I think there still is a higher symptom burden in PBC, certainly with my severe itch patients. So there's kind of, you're weighing up different things. So even if, because actually symptoms are not the same as disease risk in terms of needing transplant, that you can have very bad symptoms but actually not have very bad liver disease as such. So I'm not sure either is worse or better in the terms. I mean, PBC, the one of the more positive things in PBC is we do have treatments for PBC now. All of a sudden we have nearly soon to be 5 treatments for PBC that we have access to. But hopefully PSC will follow suit. And we can learn a lot, I think, from PBC trials and treatments in PSC, because they are both bile duct diseases. So yeah, I'm not sure I would go say worse, different challenges, but yeah.
Okay, that's great. Thank you for explaining that. The question here is it correct that the further away from diagnosis you are, the lower the risk of cholangiocarcinoma, bile duct cancer, i.e. cholangiocarcinoma risk seems higher in the initial diagnosis phase?
Yeah, so I think that question's alluding to, so there are studies to say that actually your highest risk of being, or there is a higher risk of being found to have bile duct cancer within a year of diagnosis with PSC. That's a slightly tricky thing to pull apart. It's probably because if somebody has a problem with their bile duct that is causing a blockage which causes them to be unwell and present, then that is when they are diagnosed. So yes, technically that is true, that the highest rate of bile duct cancer being diagnosed is within a year of diagnosis, but it's probably the thing that triggers the diagnosis in the first place, if you see what I mean. I don't know what
Yeah, that does make sense. Is there any link between the vaccine, and I presume, I had a look through it, is it a COVID vaccine? I think it's the COVID vaccine, but I'm only guessing. Is there any link between the vaccine and PSC? All my symptoms started 2 weeks after the second, so it is COVID, I think, second vaccine. I was then diagnosed a few months later, but I've always lived rurally by arable crops, which I know has been cited as a potential link.
Yeah, so I think I mean, obviously for obvious reasons, the COVID vaccines have been a massive, massive topic. To my knowledge, there is not data to support that COVID or the vaccine are related to PSC.
Yeah.
There are data to support other kind of very acute things that the vaccine may be related to. I think I'm a big supporter of vaccination, FYI, but so no, I don't think there is data to support it. I think it's very difficult to do those studies because if you looked at the whole population, the vast majority of the population in the last, 6 years now would have had a COVID vaccine at some point surrounding when they were diagnosed with something. So I think it's very difficult to really bottom that out properly. But to my knowledge, there's not a confirmed link between the vaccine and PSC.
Okay, thank you for that.
But I would encourage all my patients to get the COVID vaccine.
Yes, yes, absolutely. What are your views on drinking alcohol regarding PSC and pre-transplant?
So PSC in itself, there is not a relationship with alcohol. So alcohol is not a risk factor for PSC. Alcohol is in excess is bad for the liver. So whether you have liver disease or not, we would obviously advise drinking within recommended guidelines, which are 14 units a week. PSC patients who have working livers aren't cirrhotic. I do not advise that they should be abstinent from alcohol. I don't think there's any evidence to say they should. If you have advanced liver disease, I think it doesn't matter what the cause is. I would advise people not to drink because you don't want to. That's not because the alcohol caused the liver disease, but because alcohol challenges the liver. Yeah. So actually, my PSC or autoimmune hepatitis, whatever patients, I would advise them not to drink alcohol, but not because I think their liver disease was caused by alcohol. But if you have advanced liver disease, you don't want to stress the liver further, I would say.
Okay, thank you very much for that. I'm going to take one more. Questions are coming in thick and fast now, of course, but we've only got time for one more question because I know, Dr. Dyson, you've got another meeting at 2:30. So the question is, if you're diagnosed with PSC and suffering symptoms again, but no blockage shows on an MRI, what would be the next steps?
So yeah, if you have a specific narrowing blockage that we can do something to, then that's a different thing, and that's where you're talking about, camera test, the ERCP, or even an operation in some people. If there isn't a specific area that we can kind of do something to, then really the management of PSC at the moment is all about kind of recognizing risk and monitoring for complications. So those things we talked about in terms of looking for inflammatory bowel disease or keeping a close eye on inflammatory bowel disease if we know it's there, regular scans, regular blood test monitoring, addressing symptoms. Every time I see somebody, we should be saying, do you have any symptoms, exploring that and treating them appropriately. So at the moment, if there isn't something we can kind of intervene with or kind of stent open and what have you, it's all about looking out for the future, monitoring for the future, and checking that disease is progressing.
Thank you. And somebody comments on the questions and answers section. Thank you, Dr. Dyson, for such full and understandable answers. And I completely echo that. Thank you so much for joining us today and giving up your time. I hope you have a chance to get some food before your next meeting, which is in about 2 minutes, so you probably don't. But thank you so much for joining us, and thanks everyone who's participated in today's Ask the Expert for joining us as well. The next Ask the Expert is the 28th of May with Dr. Deepak Joshi, and it's about moving from childhood to adult care in PSC. Obviously, that won't apply to everybody that's in our community, but it is a very important topic nonetheless. We do have a face-to-face event, which is our information day, and that's before the next Ask the Expert on the 3rd of May in Newport, with headline speaker is Dr. Andrew Yeoman. So that will be a great event, and I'd urge anyone who can make that to sign up for that. It's a free event, and it's in Newport, so that will be great. Dr. Dyson mentioned our alert cards, which you can order. I would urge everybody to get hold of one of those. You can take them to A&E, and that explains what you think that you are going through, if you like, a cholangitis attack. So the alert cards can be ordered from the PSC website, PSC support website, and also all the clinical trials for PSC that are currently running are on our website as well. So just want to end there by thanking everyone, and particularly Dr. Dyson, for joining us today. Thank you.
Thank you very much.
Bye-bye.